So first question. Yes, over here.
Hi, I've been listening to all of you today and you've been excellent actually. But I've got a slightly controversial question, which is, you all seem to use amitriptyline as a first-line treatment for neuropathic pain, but where's the medical evidence it actually works? I don't know anybody that's had it who hasn't moved on to another drug.
Like I said,
So the question is, does amitriptyline really work? Is there the research evidence to back it up? Most people move on to another medication.
I have to admit I never use amitriptyline, but I use nortriptyline because it has less side effects than amitriptyline. The reason why it's very widely used is still the cheapest tricyclic antidepressants available. I think it's quite a dirty drug. It has got lots of different actions. It works a little bit as a local anesthetic. It works as a tricyclic antidepressant, but the local anesthetic effect can sometimes work better in other people than in some people. So if patients come to me and they say they had some benefit and it's actually quite effective in things like postherpetic neuralgia, so I leave them on it. I wouldn't take them off an effective treatment, but when I initiate this type of drugs in my clinic, I start with nortriptyline because it's a bit cleaner. The evidence, it's not licensed for neuropathic pain, but if you look at kind of numbers needed to treat, for different drugs, the tricyclic antidepressants like amitriptyline are probably still the best in neuropathic pain. The NNT is, only you need to treat 3 patients to get 50% pain reduction. And I think the reason for this is that it actually works very well in postherpetic neuralgia patients. That's where the numbers come from, but it has never been tested in things like central pain syndromes. So we just derive, the effectiveness in neuropathic pain to use it. But I agree, it has lots of side effects, and like I said, that's probably the reason why it's not very well tolerated. But
Jim, are you okay with that second mic, or would you better turn it off? We're getting feedback through this. Yeah, we're getting feedback through the speakers.
Sorry, there are very good trials on amitriptyline diabetic neuropathic pain postherpetic neuralgia. So probably not in transmyelitis, I agree. There are very good double-blind randomized controlled trial evidence saying amitriptyline works. The problem with rare conditions are it's difficult to get double-blind randomized controlled trial in rare conditions. That is where the difficulty is. We have to extrapolate from other, similar pain conditions. It might not work. I fully agree, and there are lots of side effects with that. Okay.
All right, next question. Oh, wait, there's someone over there. Was there someone? And you have a question, okay.
I want to ask about Sativex, which I've tried to access as a pain relief for TM and unsuccessful. The hospital that I've tried to access it through, their ethical board only releases it for MS sufferers, not for TM.
I can say something.
Yeah, I can tell you what I have used. I've got few patients on Sativex. Sativex is difficult to get approval from. So what you need to do is to get what is known as an individual funding request, or IFR, through the local authority, now called the CCG, not the PCT, the Clinical Commissioning Group. Unfortunately, there is no evidence that Sativex works anything outside MS. That is where they're going to come back. One of the problems with CCGs always come back, and I have a constant battle with CCGs trying to get approval for, or funding approval, the NHS system in which you can't prescribe a drug, even if you say, I will. There are lots of patients who come and say, I'll pay for the drug, can I just get the drug, please? Even then it's difficult to do that. So what the CCGs want, or do not want, is they approve for one person, and the floodgates are going to open and say, oh, you approved for Mr. A in Shropshire, so why can't Mrs. B in Warwickshire have it? And that is when the issues will happen. So that is one of the reasons they're holding back. I don't think there is much evidence to support one way or the other, but getting it through the individual funding request would be the easiest option. Well, I say easiest, one of the easiest options you can try, rather than hospitals will not fund it by itself. You need to come through the CCG, which is supposed to fund it.
And has it been useful in the patients you've tried it with?
It certainly works for MS patients, but the problem is the transmyelitis, or NMO, it has not been approved to use. I've got patients who've got other conditions, stiff person syndrome, for example, in which it's supposed to be very useful. But it's an extremely rare condition. You're talking about 1 in a million diagnosis. So, we are looking at, a handful of patients. So you're never going to get randomized controlled trial evidence for that.
On the other hand, that should reassure the CCG that opening the floodgates wouldn't cost them very much.
I wish. The number of IFR requests I get refused is something like 1 every other week.
Like I said, Sativex is now approved in Wales, so you can move to Wales. That's only one option.
That's for MS.
Yeah, again.
That's for MS, not for.
But again, the evidence for pain in MS is not that great. It's quite helpful for spasticity. And we had the big discussion on our drug and therapeutic committee in the Walton Center. And obviously, we have 3,500 patients with MS or something on our books. And it's always, like you said, the cost problem, that if you open the floodgates for all these patients, and we have really thoroughly looked through the evidence, and the numbers they have studied this are quite small. I have been involved in some of these trials myself, and the drug company is quite pushy. They have sold, the marketing rights now to a German company called Bayer, and they have improved, the marketing strategy, whatever. And I have to say, I did my MD with cannabinoids in pain, and I don't use them because, the worldwide controversy discussion is going on that there's obviously medical cannabis you can smoke, which I can't really advise, or you can eat as cakes. And that works a bit better in terms of it's a mixture of the plant is different from the purified cannabinoids you get in the spray. And there's a high risk, particularly if the THC content in the spray is very high, that you have a much higher incidence of psychotic diseases. So if you go to all these kind of balanced discussions, there are always people in advance for it and people who speak against it. And personally, because I worked with a lady in Australia who has done lots of research in psychiatry about cannabinoids, that I'm quite careful. I wouldn't really start using it widespread because there is a high risk of inducing the psychotic stuff. So we have to see where we get there. But it is getting now kind of fashionable in epilepsy. They are doing cannabidiol trials in epilepsy, and hopefully it will become eventually in the future. But to say from my point of view, there are new drugs who are actually utilizing the endocannabinoid system in the body, which block the kind of degradation of endocannabinoids. And they are in phase 2 and 3 studies, phase 2 studies at the moment. And I think they are much more precise, to influence the kind of manipulating pathways rather than flooding the whole body, with THC, which then has all the psychiatric side effects and whatever.
Next question. Yeah.
Thank you. Sorry, this is my second question of the day. With my recovery, I found that my right side recovered quicker than my left side, and I now have a dropped foot, basically. Is there any explanation as to why that happens, why one side recovers quicker than the other? And what could be done to kind of improve that? Because I've been told, well, it's really, really difficult to say whether you're going to get used to your foot back again or not. I know other people are in various stages, but it's just a question that I'm not getting an answer from my neurologist, so I don't know if anybody's got advice on that.
I think that's a crystal ball question. I think it's difficult. It's not easy to say because as I shown the diagram of the spinal cord, there are millions of tracks going back and forth. The spinal cord, millions, probably billions, so going back and forth. And it's difficult to say what proportion of the tracks, and we always have a tipping point. So you have millions of tracks and you need, let's say 50% of tracks for us to work. Even if you have 45% on one side and 20% on the other side, you'll still have the same weakness, but you wouldn't know. Okay, so there are 2 or 3 things for that. So it could be that your right side had less damage than the left to start off with, even though the weakness was similar. Okay. 2, we know that if you're handed on one side, if you're right-handed, your left side of the brain and the nervous system is supposedly better, wired. So your left brain is dominant if you're a right-handed person. So the tracks coming down that obviously cross over to the other side, and we can probably say that side is slightly more dominant. But I don't think there's any evidence for that. I think the more likely reason is the number of tracks involved to start off with are probably more on one side than the other, even though the end result looks similar.
I said I can only say something, you know, I showed you this picture with this TMS machine, and I had this done myself as a kind of a control person in a trial, and I play table tennis, and I'm right-handed, and I had my motor cortex mapped, you know, so the area for my left hand is only half the size of my right hand. So I would expect, you know, during the recovery phase, when I start activating my muscles and tracts again, that probably my right side, you know, would recover quicker, because there is just more downgoing information from the motor neurons, you know, to activate the remaining tracts again. And that could be the explanation, you know, that happens on one side slower than the other. And one of the things we are trying to establish is use these TMS machines, you know, in early stages to actually activate these motor neurons kind of this is artificially, so that you get the kind of guidance of electrical signals into the motor pathways. Rather, it stops not happening because you are in pain or there is some connection disrupted. And if you do it top down, then there is probably a chance, you know, to get them actually reactivated. So there is a kind of a big workload going on in rehabilitation medicine, where they try to use these techniques, you know, to enhance recovery in spinal cord injury and in kind of quite a few neurological conditions. But as that's my kind of explanation, that's probably coming from the top, including, you know, all the kind of different recoveries on the tracts, which can explain your kind of different recovery speed in the sites.
Thank you very much. That's more information than I got so far.
Right, there's a question back here. Yeah, over there.
I have a tightness around my breastbone, so every time I move, it gets tighter and tighter and tighter. So that stops me from doing exercise. I mean, will it get any better if I do exercises, or what do I do to make it a little less painful?
Yeah, I can say, I think, you know, this tight bend is probably, because it's in the thoracic region, you know, we see this quite a bit, that there is probably some connection to the sympathetic nervous system. So if you exercise, you know, you produce adrenaline, and that could make the pain worse to a degree. I'm not sure if it's very numb or how the kind of skin reacts in this area, but what I try to tell my patients is, you know, that this pain is a pain caused by the damage to your nervous system. So it's not really pain which fulfills the normal purpose in life, like warning you from tissue injury, because this pain is completely abnormal. So a pain management program, for example, would try to teach you strategies, you know, to ignore this pain to a way, or try not to be distracted as much, and then still enhance kind of exercises. But I kind of understand that's sometimes quite very difficult to do. But because it's fear avoidance, because every time you get this pain, it causes fear, and then you don't do the exercises. So the idea would be, if none of the medication works or whatever, I don't think that will in this kind of condition, then at least, you know, don't stop the rehabilitation process by stopping the exercises because you get pain. You just need to learn to distract or disconnect this kind of warning sign of pain, you know, from what you experience, and that sometimes can be quite effective.
Well, I've been trying that. It's quite difficult because it just seems to get tighter and tighter. And every time I try to get over that, it just throws me, and I get so despondent and not want to do anything. But my doctors wants to give me more painkillers, which I don't want any more painkillers. So I think I'll just carry on trying to do some exercise and see how far I can get that.
Can I comment on that?
Yeah.
Just a comment on that for me is that diazepam works to take it to a level where I can do something, and it has had an effect, and it's the only thing that works when I get that really bad banding.
This sort of band-like sensation is very common. Sorry. I'll tell you what I think what she said was diazepam works in lots of patients. Diazepam, Valium. The tight band-like sensation is something is very typical of spinal cord. It doesn't have to be the chest. I've got patients who've got tight band across the ankle, or the knees, or the legs. That's something that is very, very typical of spinal cord. And I think some of that is probably the muscle spasm as well. So that is probably where the diazepam helps. So it needs to find out whether it is a muscle spasm which is the problem, or the pain, neuropathic pain. If it's neuropathic pain, diazepam might not work. But if it's a muscle spasm which is causing the stiffness, diazepam might work. So it's trying to find out between the two. It's not easy. And I'd be lying to say there's a magic drug. You'll just take it, it'll get better.
Wait, Farshida, you raised your hand.
May I suggest to use a distraction technique? Could either use a corset or a bandage, new parade type of corset around your chest, and that actually gives you a different sensation. So while your brain is busy thinking that I've got this different sensation around your chest, you can then do your exercises. You could also use a small vibratory around your chest. That also reduces the vibration itself. It's another sensation goes to your posterior ganglion and distracts your brain from thinking, oh, I've got this banding. So you can use variety of distraction technique or brushes. That also helps.
Okay, this gentleman over here in the green, and then Doreen after that.
Thank you. I just wanted to ask a question about pseudo relapse. My wife suffered a TM attack about 7 years ago, and we consult with Dr. Simon Ellis at North Staffordshire. It's absolutely fantastic. He put her on a high dose intravenous steroids, and you largely recovered from that. But just in the last few months, she's had a second attack, but the clinical signs from the MRI scan, we're still waiting for the banding test to come back, but the MRI scan showed no change in signal whatsoever in the brain or the spine. In fact, the lesion is C2, C3. It's quite high, but it's very small. But she's got new symptoms. So I'm just wondering what the sort of thinking is around if the clinical signs haven't changed, but new symptoms, particularly Lerman's sign is now appearing, which didn't have before. Just like to understand the collective thinking around that, if I could, please.
Yeah. As I said early on, can you hear? As I said early on, you do not have to have spinal cord abnormality to diagnose a relapse. However, it depends on the history is the key thing here. So are we talking about a symptom which was, I know you just said you haven't had Lermid sign before. If you're talking about a symptom which was there before, early on, and then went away and it's coming back a bit more, that is probably slightly different. But if it's a new symptom, I would certainly think that's a relapse, rather than exacerbation. We can't call it exacerbation if it's not there before. Yeah. But the word exacerbation means it exacerbates something which is already there. If it's a new symptom, by definition, I will call it a relapse. If you don't have scan abnormalities, it's probably a good thing because it tells you the prognosis is good. Okay. The question then is, what can I do to get that symptoms under control? We know that intravenous steroids and steroids help in the acute phase of relapse. So if at all I'm in doubt, I'll give them steroids. That's what I do. There is no evidence long-term steroids make a huge difference, with regard to long-term outcome, unless there are any new physical signs and things like that. So I would think if symptoms are new, I would call that a relapse with or without an MRI change.
Thank you.
Right, interesting. Oh wait, I'm sorry, there was Doreen here, and then, yes, I've got you clocked. We'll get you next.
Hi, I just want to go back onto the exercise thing. A lot of us here have mobility problems. I was actually diagnosed with TM just under 2 years ago, and subsequently diagnosed with MS that basically might have come earlier when I was a child. Now, I've been trying to get some strength back in my legs, because basically I used to walk everywhere before. I had good legs, I had good strength. Now I don't. Would you suggest taking like my gabapentin, my antitrypsin, before I go and do my exercise? Because I go on the exercise bike and I'm lucky if I can last 2 minutes, 2.5 minutes before I've got the spasms in my legs. Then trying to get off, I will basically collapse onto the floor, and then it's taken a good hour or so before you can get back, because basically you tense up, your chest goes, you have to fight. to get your breathing under control, and then you don't want to go back up for another couple of days because you haven't basically got the strength to do it. Now, like most of us, I don't want to walk with my stick much longer. You know, I want to be able to walk again and do things like I used to. You know, I was never a long distance runner, but you know, I want to be able to say I can get up that bank without holding on to somebody else. You know, so my main thing is to control that pain before it starts. Is it worth taking something first? And if so, how long before? Also, you've got like the painkillers like that. I've got codeine phosphate that I would take when I get like severe headaches, or my pain gets really bad, which kicks in about 20 minutes, it's great. You know, and then take over my painkillers as well. So, you know, is it worth taking something first? And probably maybe a drink so you're hydrated before you start.
So it's like taking pain as a preventative measure.
Yeah, take it before you actually start, the same like taking fluid in before you start. Because by the time you come up, you feel like you've run a marathon, even though you haven't. And you've probably only done certain, like, you know, not really. I mean, they say exercise is good for you. The more exercise you do, the more strength you get, the better you get. But it's getting that exercise. There's no point going to a gym because basically you'll be looking if you can get up the stairs in the first place.
Right.
I mean,
I can say something, you know, I wouldn't take amitriptyline in the morning because that will just
I actually take it on a night. It helps with my spasms and everything. So like.
But that will just zonk you out, you know, 30 minutes after you have taken it. And it's not a drug who works kind of acutely, you know, it takes a few weeks, you know, until the effect takes place. With gabapentin, if you want to do the exercises, I would take it an hour or so before because it's a 3-daily drug. And that would be a good thing, you know, to take the painkillers before you do this kind of exercises. Again, with opioids, you know, there has been a shift a bit in my thinking, you know. If you take opioids like codeine, you know, chronically for chronic pain, it should be given as a long-acting version, so MST rather than Oramorph, and this kind of thinking. But like I said, I see quite a lot of post-trauma patients nowadays, and I think if you combine it with a functional improvement, as long as you don't go above a certain 24-hour dose of an opioid, which should be really lowish, something like 50 milligrams nowadays, then I don't mind, you know, and it's probably not a bad idea if you can then do the exercises kind of better by taking some Oramorph or codeine or whatever, you know, half an hour before you do them, then I wouldn't dismiss this completely anymore. But I think it needs to be a part of a plan with your GP, you know, that the drugs are not going to be escalated indefinitely. You know, if there's an improvement in function, then probably try to reduce the painkillers eventually. But, you know, you seem to have lots of, you know, you need some pacing skills, and that sometimes can be helpful to be learned with a physiotherapist, you know, to give you some kind of very low intensity exercises and then repeat them, you know, for up to 3-4 weeks until you have the strength, and then go a step higher rather than, you know, jumping onto the exercise bike, do it 2 minutes and then you can't move your legs anymore and then you have to stop.
I have to say it's on the very lowest setting.
Yeah, I know.
You know,
if it's the lowest setting and you can't do it, then you probably need to do something before, like aqua aerobics or whatever, so that you train your muscles up, you know, to sustain this part and then go to the next step. If you have, you know, unrealistic targets and you can't achieve them, then they only frustrate you. So sometimes it's worthwhile to get some advice and then probably start off in a pool and do water aerobics, you know, to get into this non-anaerobic kind of exercises so that you don't get any acid production in your muscles, which then put you off it. And I think that's, you know, a kind of a better rehab concept than, you know, going in this burn and bust cycle, you know, that you can't do things. It takes a long time to find the right balance, I believe, you know. But
so
you need
really
to.
Would that be recommended for your neurologist then, or you go for your doctor? Because to be honest, your doctors aren't going to refer you for a hydro pill.
Physiotherapy is the right approach there, rather than neurology. So physiotherapist will be the person who will give you the graded exercise therapy. What we call is graded exercise therapy. So grade. So depending on how much you can do, we can give a graded regime. So the first 3 weeks you do this. It might not sound like much, and you would think, oh, I can do this. Why are you giving me this? But that is to bring your reserve up, and then slowly move on. So sometimes what happens, the very first step might look and feel too simple. And that is when people actually step on to the third one straight away. Look, this is too simple. I don't want this. I can already do that. But the whole idea of doing that is to condition your muscles so you can go to the next step, and then the next step, and the next step afterwards.
Okay, and there was a question over there.
Can I add something?
Yeah.
To that? I just want to add that any of the patients that have TM, or especially MS patients, if you have we used to advise a lot of patients that had very what they call heat-sensitive symptoms. So symptoms that were, if their body temperature is elevated from core exercising, or if they ever had an infection like, oh, my numbness comes back or my weakness comes back, and if they wanted to really get committed to an exercise routine, we used to recommend that they have a lot of cooling mechanisms on place, because a lot of MS patients, and this is at least MS, and a lot of TM patients have impacts on their sweating ability. And so you can buy ice pack, like those reusable ice packs that you can put on your neck or on your arm. They have t-shirts you can buy online where you put in the freezer. And for some of our younger patients that had TM, that say, oh, I really want to exercise, I would recommend for them to bring a cooler with some of these things, and when they take brief breaks, help themselves cool faster so they could get back right into it. And some of them, not all of them, but some of them have found that rapidly cooling themselves would help for them to get back, and instead of taking 45 minutes to finally cool down, and then they're so exhausted after resting for so much, and then they find it harder to go back into it. And it's something that's really seen with some TM patients and a lot of MS patients, because they have a lot of myelin loss and they have very heat-sensitive symptoms. So just something to think about.
Thank you. There's woman over there.
Hi, mine was just about paediatrics point of view, really. Which centre should they all be going under, and who's actually the lead in the UK on the paediatric side? Because we all seem to be going under different areas.
Dr. Minglim.
I think, as I was saying, it's a very rare condition in the first place, and not many of us would have, super expertise. So if you look at, a TM study that we did not too long ago, we know that in a year we probably see about 40, TM patients in the whole of the UK. There are many big pediatric neurology centres. Most of the ones listed that are part of this trial, the 10 to 12 of them, would have a pediatric neurologist who is very comfortable in dealing with patients with TM. So I would recommend any of those centres.
Okay.
I have a list of the centres.
Sorry?
I have a list of the
Barbara's got a
centres.
list of the
Okay, because the one we're currently on isn't the Midland Centre for Spinal Injury, and we've only seen Dr. Bassmer once at the Birmingham Children's, and that was not very successful. And my second question was, in children they didn't think pain was an issue, but as going into adolescence it appears that the pain seems to be increasing.
That's a pediatric thing, I think.
Yes, no, I think I've seen very much, mirrors what everyone has said today, that sometimes children don't get pain, but children do get pain, sometimes, and the management is no different to an adult having pain, bar the strategies and the treatment choice, because certain drugs that I can't even spell that you're talking about, one wouldn't prescribe in children. Yeah.
Okay. Next question. Samantha? Barry, you're getting a great workout?
Yeah, he's covered a lot of ground.
He'll have done the mileage. Hi, Samantha, in the white shirt.
Two mics for questions.
Basically, I was listening slightly, but not taking a lot of it in. I know that sounds really bad, but with the muscle spasms, I did catch that it's part of the recovery. How long could this period last for? Is it something that's a couple of months, a couple of years, Because it just feels, I know you can't say it's like how long a piece of string, but it's just that kind of fear.
Yeah, I think you sort of answered it yourself, isn't it? It's not easy to say how long it's going to last. As I said, I've got patients who had muscle spasms lasting for 2 days. I've had patients who had muscle spasm still going on after 2 years. So I think it's very difficult to say how long it's going to last. It depends on, because one of the reasons for that is it depends on how there is some natural regeneration happening in all of us when you get spinal cord injury. And that depends on where this regeneration is going. If that regeneration fibers are going to the other muscle fibers which actually causes spasms, that is when the spasms will be a problem. Whereas if it is happening only for a transient period of time and then you got to regenerate back to a normal muscle fiber, that won't be an issue for a long term. So I think it's difficult to say how long it's going to last, but usually it's few days to few weeks. But I presume it is not the case in your case. That's probably why you're asking it.
Probably about 18 months.
Yeah.
And it gets to the severity that it's actually, I've ended up with cases of tendinitis where it's just pulling so much from it. So it's it was,
yeah.
I got a little bit hopeful when it was part of the recovery part.
Yeah, the drug I mentioned earlier on, carbamazepine, is something I often
I'm
very
on
useful,
carbamazepine.
very useful for
2 years.
that. But it doesn't work in everyone though.
Yeah. Thank you.
Any other questions? It's a great opportunity. Get them in, definitely. Yeah, absolutely.
We've learned today, I think everybody here has faced depression at some point, especially with transparency and what you go through. In some cases, you actually get the symptoms over gradually, so over a number of days. There are a few people here that I've spoken to also who kind of it came on really quickly, so whether it was like 20 minutes, whether it was half an hour, whether it was an hour, and that causes a certain amount of trauma to you. Yeah. And I'm seeing a psychologist, and they've just diagnosed me with having PTSD. Is that common with TM sufferers, or am I just really crazy?
Well, there's a spectrum of symptoms, and PTSD does encompass depression as well as anxiety. So a lot of PTSD sufferers typically who are veterans, they will typically complain of not just the trauma of whatever they're experienced, intrusive memories, the flashbacks. Depression will be very high, and it's difficult to say that this is depression, this is PTSD, this is anxiety. If you go through a very life-threatening chronic illness, and as I was saying, where it's uncertain, it's unpredictable what your prognosis is going to be, it is like a trauma. And you do, I think, re-experience the way you found out, who told you, what they told you about it, it goes through your mind. I don't tend to mind what people call it, PTSD or depression or anxiety. The important thing is the approach to the management of the problem, and it's got to be multidisciplinary. So we use medication. We have very excellent specialist nurses who are the first point of contact within probably about 48 hours of getting a referral. And then we have a dedicated psychology service which works along CBT models but also psychotherapy. And then we use very aggressive psychopharmacological management strategies to deal with it quickly.
Are these sort of services available by your GP?
No, because as I said in my slide, you could end up seeing a community mental health team, and they're not really comfortable with organic conditions. They wouldn't know what transverse myelitis was, and they would probably say it doesn't fit their cluster. And I think seeing a neuropsychiatrist in the UK is extremely difficult. There are only about 25 full-time NHS neuropsychiatrists in the UK. I think I was talking to Dr. Fink. They're a lot more common in Europe and America, but not here.
Can I just follow up and ask you for her actually, how do you actually access those services? How does she get in front of those 25? Because I'm sure there's a lot of you in this room that are being passed on from pillar to post, and it's really not fair.
Well, I hope that today you'll all be familiar with the fact that there are neuropsychiatrists. Most of them are in the independent sector. Only a few are full-time in the NHS. And the thing to do is go to your GP and say simply that you think you have a rare condition which is neurological, and this condition has both psychiatric and neurological features, and that you would like to be referred to your local neuropsychiatrist. You be prepared to have a bit of a wait. To see me, well, to see me is 6 months, but I mean to see a member of my team is probably within a week, and they escalate up. So if the problem is in need of me, then they'll escalate it quickly. So, you know, we work very well and efficiently.
Other questions? Going, gone. Right, now we move on to some gift giving to thank our speakers. So I have invited Joanne Laquiwa, who, did I?
Yeah, Laquia.
Laquia.
Nobody gets it right.
who did it helped us out a bit because she lives just outside Birmingham, and she, you know, did some site visits for us to get some questions answered. She had the thank you gifts where the speakers delivered to her and gorgeously wrapped them. So I just want to thank you, and can you please present our speakers?
Yes, yeah. I'm sure you'll all agree today that our speakers have done a wonderful job. And they really have, you know, been a tremendous help to everybody, because I think we're all the same. We all sort of struggle to get information, so having you all here today giving us all this information has been really helpful and beneficial, well, to me anyway. So I've just got a few gifts to give, so if I can sort of have all the speakers come up and I can present them. One thing I would say was Barbara did sort of suggest that we got something that was relative to Birmingham area. So my first thoughts were you were all going to Cadbury's for the day. But after careful consideration, we decided that sort of years ago there was a society called the Lunar Society, which was leading innovators for Birmingham, and one of them was Josiah Wedgwood. So we've got you a piece of, well, it's a Wedgwood mug, and hopefully every time you drink out of it, you'll think of today. Okay? All right. Thank you, Dr.
I live in the original Cadbury's family home. So.
Thank you very much for today. Thank you. Next.
Thank you very much.
Thank you. Thank you.
And we have two neurophysios.
Please.
Lindsay and Farshida. And Amanda Andrews, is she still here? And Carolyn Young isn't here. And has anyone seen Amanda from Coloplast? No? Okay. And Carolyn isn't here.
Okay.
And that's it. We have an extra.
Right.
Brilliant.
And yourself?
Oh, no, I wasn't planning on that.
Okay, I'll leave them.
Right. Well, I think that concludes our day. I hope you all had an enjoyable day. The whole idea was around neurorehabilitation and providing not just the TM perspective, but other perspectives around neurorehabilitation, including the neurophysiotherapy, the bladder bowel, coping emotionally and thriving with the equipment, charities that provide other services. So just looking at the holistic whole version of the person in terms of ongoing recovery and rehabilitation. And also today was quite special in that we had 153 participants scheduled to come, and that was the most ever at a conference that the TM Society has had so far. So that's a nice thing to have had as well. So it's been really lovely having you here. If people are hanging around tonight, some of us will still be here, might see you in the bar. And thank you very much for coming, and have a very safe drive home. Thank you.